Thank you, Dr. Muhammad. We will move now to the next speaker, Dr. Eisa Faqih. Dr. Eisa Faqih is consultant medical genetic in King Fahd Medical City in Riyadh. He is interested in skeletal dysplasia and he will talk about bone genetic disorder. So, welcome.
السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم بكل خير، الله يعطيكم العافية، جزاكم الله خير. Thank you very much دكتور علي. I wanted to thank you very much دكتور محمد، جميع الزملاء في منطقة جيزان. يعطيكم العافية جميع nice organization and the nice hotel that I did not expect it to be in جيزان صراحة. ما أعرف أول مرة أعرف إنه millennium hotel is in جيزان. Thank you very much. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا واجعل علمنا حجة لنا علينا. الله يعطيكم العافية. I'm going to present to you my experience of the last 20 years in the genetic diseases in general and some of the associations with dysplasia or skeletal dysplasia. So this experience is based on the collections that we have in King Fahd Medical City and based on the cooperations of the several colleagues from all over the kingdom that the export pseudospatial studies, whether this is real X-rays, radiology, or specimens with patients also. Thank you very much for that. So, as expected, the genetic diseases in general, it's very heterogeneous, and this is typically been on this field of medicine, which is the bone morphology or dysmorphology. So, we expect it to be a heterogeneous disease that has many manifestations from the extreme lethality to the extremely asymptomatic about being stunted or short. So this is the pathophysiology of bone, as you know, it's a structures plus metabolism. So if anything that happens to the structures of metabolism, expect the bone to be affected. And this, the manifestations might be obvious as the clinical physicians be able to detect, or you do probably some of the simple X-rays to see the bones and how it looks like. So their natural histories, prognosis is based on the early presentation or sometimes late presentation, whether the patient is treated, not treated. And this is, it happens also to the skeletal dysplasia or the bone disease in general. So the core manifestations in pediatric in general, it comes out the short statures, whether this is in terms of micromelia or in terms of only short stature that cannot be detected by obvious bony abnormality. So in general, it has also extraskeletal manifestations. Examples, achondroplasia. They are not only short, but also they do have manifestations of breathing, cardiac, as well as the manifestations of the cervicomedullary stenosis. So this is a typical one extreme, as I mentioned. So you see those extremes. The top, the colored one, is a baby who presented with no limb or a very rudimentary limb bond. So this is an Awada syndrome, which is now it's well-known syndrome caused by one of the wingless gene. And the bottom one is the 3M syndrome, and I guess the specialized endocrinologist will be able to detect the 3M syndrome based on with no endocrine axis abnormalities at all, normal skeletal manifestation, but also they might have some sort of the very subtle facial dysmorphia with no hormonal abnormalities. So if they are focused well in their face, they might have some sort of flagging signs of what we call 3M syndrome. So, again, back to the same, we have a genetic disease that is known, and there's a genetic disease that is unknown. So we are an extreme. The examples of very well categorized and published, and even with the treatment, is the achondroplasia, that everybody is aware of that terminology. And we do have several, probably hundreds of skeletal dysplasia are yet to be known. So the science is ongoing, the research is ongoing to know the differences between the some sort of subsets of skeletal dysplasia. We are yet doing an exome, not yet coming up with any positive results. So, in general, everybody is saying common, but relatively common, I would say. The genetic diseases, not only in the cardiac or the nephrology, but also the skeletal and all manifestations. Dr. Hassan nicely talked about the polygenic effects, also the multifactorial inheritance of the very massive common diseases also. So we estimated the bone disorder to come in the frequency of 1 every 4,000 to 5,000 baby born, and those might have a subtle bone dysplasias manifestations, or might have also an obvious lethality, like for example hydrops fetalis, fetal akinesia, and also the severe micromelia. So at birth we expected those babies with a lethality to be stillborn, 13%, and 14% of neonatal deaths are probably they will have some sort of a skeletal manifestation, or whether you see it or not see it by the X-rays. Based on my experience, I assume everybody probably agree with me on the four most common genetic diseases that concern the bone, which is the achondroplasia, which is the common non-lethal form of bone diseases. Achondrogenesis is the most common lethal. Achondrogenesis is the most common lethal manifestation. We've seen over the last 20 years probably around 9 to 8 families. So those are mainly tips of iceberg of those cases not picked up and not diagnosed and not even sequenced. And then it follows the other osteogenesis imperfecta, osteoporosis, and the thanatophoric dysplasias. The common presentation, as I gathered them all, so for the easiness of the memorization, we might have the lethal manifestation, the extreme form I talked about it earlier. So lethal, contractures, arthrogryposis multiplex congenital is the obvious lethal manifestation, and also it can be as a subtle short statures. So this is again a message to the chronologist to come up with a very hint. Don't do just only simple hand X-ray that consider your subspecialty. Do the whole as one image, so we will be able to easily see if there is a metaphysis, epiphysis, diaphysis, or even platyspondyly, or scoliosis, or kyphoscoliosis. So the second is the bone undergrowth. Not only the three that I mentioned, but also sanguine also carbonic anhydrase, also the many syndromic diseases that we are aware of, that they don't have usually a subtle skeleton, but if you dive more, you will see some sort of metaphysis, epiphysis, or diaphysis changes. And then the bone segmentation defect, which can be generalized, which can be localized, micromelia, or fucomelia, or rhizomelia, or the other manifestations, or the scoliosis. There's several manifestations of the skeletal dysplasia picked up by orthopedics only. So they do have an X-ray, they find scoliosis, kyphoscoliosis, they send it to us. We'll do skeletal survey, we find some sort of subtle manifestations in the tubular bones, metaphysis, epiphysis, or diaphysis also. Rickets, again, it's a congenital disease or a genetic disease of bone, so it's a mineralization. So this is, again, all hereditary rickets, skeletal dysplasia also. In addition, we do have lots of skeletal dysplasias that are related to the hypodensic crabiness, which is basically osteopetrosis or osteogenesis imperfecta. So the lots of consortiums now coming up with classifications in the aspects of genetics, including also the skeletal manifestations or skeletal genetic diseases. So the nosology, the first nosology has been established in 1970s with a group of experts on bone dysplasias. There are many names gathering every year to come February 2023 in the American Medical Genetics by Asher Groups. So the nosology based on the gathering all the skeletal dysplasia in around 550 plus genes and more than 770 associated diseases. So those are the skeletal dysplasia consortium. They come up with like diseases that we've been gathered. So basically those are 41 groups divided to several subgroups, and I'll give you an example of those diseases that we encountered over the last couple of years. So this is a simplified group. So they classified based on the, for example, the biochemical pathway that has been gathered within that specific group, and they gathered also in group 9-17. Those are localized based on the regional distribution of the group disease, and then the other rest of the groups up to the end of the 41 groups. Be remember, segmentation defect, it has like a group for the geneticist or the pediatric to come up with like a nomination of that particular disease. So we have a micromelia, rhizomelia, mesomelia, and acromelia. Every segment it has like an example of a disease that approximates the diagnosis of the clinicians to come up with. So, and there are also, in addition to that, there are there is clinical indicators that come up with a clue for the diagnosticians or the clinicians to come up with. For example, if you have this child with a big skull, anterior foot open, this is also, we call it Beckley dysostosis. So again, this is a bone sclerotic form of bone dysplasia that they come with a manifestation, pancytopenia sometimes, are being stunned and short, but the indicator for that disease is the large head, open anterior foot sclerotic bone. Again, there are several diseases also share the manifestation in disproportionately large, so like the thanatophoric dysplasia, achondroplasia, and achondrogenesis also. Clever leaf skull is also a manifestation of a disease called thanatophoric dysplasia or a fiber disease. Again, those are tips of the clue signs that probably the pediatricians will be able to pick up. Again, there are also an indication of a clue that give you a diagnosis. For example, if you have a neurothorax, think of a crippled, short-term polydactyly with polydactyly and without polydactylies. Heart, they might have also a clue for with the micromelia diseases like Ilsfan crippled or Julifacic dysplasia, expected to be short with a broadened diaphysis with some sort of stenotic valvular heart disease. X-rays can give you also help, forming bones and osteogenesis imperfecta and cleidocranial dysplasias, bowing of limbs, mid-shaft bowing is an indication that probably you think of campomelic dysplasia or OILs. Again, I guess every geneticist will have the right diagnosis. The pediatrics, probably if they think of a disease that's called calcification, they think of rhizomelic chondrodysplasia punctata. So punctate calcification, that is a well-known phenomenon that happens in the proximal biogenesis disorder. And there are many diagnostic indicators or flagging signs that helps the clinicians to come up with an idea of what is going on. The next is after the clinical thing to do with some sort of, I would say, screening tests like radio imaging. Be remember, this is a very crucial step forward to give you another helps to give a diagnosis. So be remember that the X-ray is not only very helpful, but also an image plus the expertise of the radiologist that should know the exact phenotype, in addition to have the right tools to come up with fruitful conclusion, I would say. Just only description is not enough. Description plus the interpretation of that exact interpretation should be put through the reports to give you a diagnosis. So the right radiologist is not almost always available in every center. So you are the best radiologist, being a geneticist that's seeing the clinic manifestations in addition to be come up with like an atlas or something like that. And now the Google makes the exercise much better for the interested clinicians. Again, we will do the bone profile for rickets. We expected the rickets or hereditary rickets to be clued by that particular bone profile, and then we will do for the metabolic or the storage diseases, the screening test with GAGs or uniform BS, and you complete the rest of it. Again, at the end, you will come up with something related to the exact gene panel, not specifically focused on the skeletal dysplasia or gene disease. I'm going to mention some of the examples of the bone dysplasias for the genetic diseases concerning bones. The common as the FGFR related. Again, this is an allelic genes that has many diseases that caused by FGFR3, achondroplasia, and thanatophoric dysplasias. Again, everybody knows the achondroplasia that has a specific phenotype and gestalt caused by FGFR, and 95% of the cases that we've seen is related to the one hotspots of the FGFR3. The natural history is well known, categorized very well. We do have many comorbidities that comes with the age, like for example that active case that's showed the cervical delivery compressions that affecting the cell magnum. So this patient is not highly likely to do manifest with apneas and respiratory problem. The interesting about the disease, it has now a treatment. Probably it has a good improvement in terms of linear growth. Again, the extra manifestations or extra skeletal manifestations still yet to be known in depth. The other allelic and extreme of the achondroplasia is the thanatophoric dysplasia. There are two forms of thanatophoric dysplasia, type 1 and type 2. All of them are lethal actually, they don't exceed the first year of life. Again, different mutations, different phenotypes, and they brought to the attention with the non-immune hydroxyphthalate, with the micromelias and the skeletal manifestations that shown perfectly well in the telephoreceiver signs in the both femori. There are several examples of the group 2 and 3, which is a collagen type 2 and 11. Those are again very broad spectrum that caused by collagen 11 and collagen 2. The commonest of this group is Stickler syndrome, and those patients presented with myopia, short statures, broad tubular bones, 5 minutes, broad tubular bones, and they do have also hearing problems. So Stickler is also Stickler type 2 and type 1 is a common among this specific group. The group 14 is that corresponding to the spondylar dysplasias, and this is what I mentioned earlier. The commonest lethal form of bone dysplasias or genetic disease of the bones in the achondrogenesis type 1A. And those patients, most of the time, they present like such X-rays with almost very rudimentary tubular bones, and they look like they're very severely hydropic. So very tiny, shrunken baby that has no breath or a birth canal. And this is a very extreme lethal bone dysplasia. Group 24 is representative by the other dense bone category. So this is basically called osteopetrosis. So there are more than 25 of osteopetrosis genes that has been established, and almost all of them they presented with a dense bone, so bone to bone, marble bone. And this is an example of a patient who presented with a cranial nerve compression effect with a facial asymmetry, and the bones most of the time looks like this. So again, there are more than 25, not only 14, 25 genes that has been etiological for the osteopetrosis. And the common that we encounter in Saudi is almost 25 cases that has been known in my cohort, and the TCIRG is the commonest among all, especially in the northern part of the kingdom. The extreme of osteopetrosis is osteogenesis imperfecta. Again, this is a disease that has many subclasses and subclassifications. The CILS classification that we are aware in the last century is now is more advanced by molecular. So there are more than 25 or 26 even diseases. They again still names osteogenesis imperfecta, but there are osteogenesis imperfecta plus. An example of that is Brett syndrome, and there are two types of Brett syndrome. This is a disease, X-ray of Brett syndrome that we encounter. Not only the OI and the BRAC, but also there are many diseases that represent a decreased bone fragility, and probably the endocrinologists and the adults will consult us with the osteoporosis earlier adults stages of multiple fractures. We've done NGS, we've done everything, but none is positive. So again, this scenario probably fits within the increasing lists of the decreased fragility, bone fragility diseases that yet to be diagnosed. Everybody knows that the osteogenesis imperfecta has many manifestations. We only have increased fractures frequencies. We do have lots of scoliosis, kyphoscoliosis, and we are practicing now the good outcomes. We are now witnessing good outcomes by the medications that are called bisphosphonates. So bisphosphonates have very advantageous outcomes in those patients with the decreased fragility in general. Bone fragility, the disorder of bone mineralization is basically those are hereditary rickets. There are many types of vitamin D dependent rickets, hypophosphatemic rickets, hypophosphatases, hyper or hypoparathyroidism that represents the group 27. And this is a representative, I make it easy for the pediatricians to conclude the types of the rickets based on the inheritance, calcium, phosphate, magnesium, and vitamin D profile. The group 36, this is an exemplified by very easy, I would say, diagnosis of spondylocostal dysostosis. So those are the vertebral and costal. You expect to have a rib plus a spine. So if you see an X-ray of the chain, if you see a patient with a short stature, kyphosis, kyphoscoliosis, have a very short tongue, do an X-ray and you see the vertebra. If the vertebra is segmented, mal-shaped, this is the right diagnosis, which belongs to the vertebral and costal dysostosis. So basically, spondylocostal dysostosis. There are more than 7 types of spondylocostal dysostosis. Some of them are recessive, some of them are dominant. In addition, we have now increasingly seen lots of cases with a cervical fusion that represent Klippel-Feil. And there are more than 5 to 7 types of Klippel-Feil syndrome now. 3 or 4 genes have been established, and yet the upcoming, I think we have more interesting 2 to 3 genes that come in the era of the genomics. Again, this is an X-ray that shows the vertebral segmentation, short trunk and short stature. So this is a spondylocostal dysostosis. Easy to be diagnosed, should not be missed. Those patients most of the time they don't go for the operation or the surgical complications. So this is a very interesting case that I think everybody should see the cutis aplasia, this reduction. So this is with or without microcephaly. So this is Adams-Oliver syndrome. So this is typical of Adams-Oliver syndrome. I brought it for the attention to exercise the audience. So in summary, we have a recessive common, being a lethal or non-lethal. The recessive common lethal forms achondrogenesis type of A and B, hypophosphatasia, OI, short rib polydactyly, achondrogenesis, and segmental dysostosis. Non-lethal form, the OI again, that probably amenable to treatment, osteopetrosis, lots of spectrum of lysostomy Eisa.